Hello, and welcome to the University of Washington, Washington Area Cardiometabolic Project ECHO, Session 9. I'm Nicole Earhart, one of the adult endocrinologists at the University of Washington. And today we're really excited to have our nephrologist, Laura Maeda, talk to us about recent clinical practice guidelines for improving kidney outcomes, blood pressure goals, kidney protective medications, and nutrition goals. Karen, will you introduce yourself?
Hi, I'm Karen Munger. I'm a registered dietitian and a certified diabetes educator. I'm working here at the South Lake Union Diabetes Clinic.
Thank you. And we're also hoping Dr. Savitha Subramanian will be joining us, our resident lipid expert. She also will hopefully be joining us as well as one of our experts. So now at this point, Laura, go ahead and share your slides and let's go ahead and start the didactic. Take it away.
So today, the focus of the talk is improving kidney outcomes based on blood pressure goals and guidelines, protective kidney medications, and nutrition. I'm the director of the hypertension clinic at Harborview Medical Center. And so a lot of my clinical interest is in hypertension. So most of the talk will be focused on that and the studies. My disclosures are that I'm a site PI for an Eli Lilly study that is for individuals with CKD and looking at tirzepatide, which we'll talk about GLP one agonists during this talk. So the objectives for today are to explain blood pressure goals in individuals with kidney disease and from the leading societies of American Heart Association, the American Diabetes Association, and KDIGO, which is the Kidney International Association. And we'll identify kidney protective medications, which is a really exciting area, and talk about those guidelines. And I want to talk about some of the controversies around nutrition goals. And I'm really glad that Karen's here. We work together at the Kidney Stone Clinic. I think going over these nutrition goals and talking about the recommendations will be how I end the talk. So first of all, why do we care about hypertension? The main concern, of course, is these end organ damages. That the brain, of course, can lead to retinopathy and dementia, stroke, left ventricular hypertrophy in the heart, systolic and diastolic function can lead to cardiovascular disease, myocardial infarction, and then of course the most important is the nephrosclerosis and the impact on the kidneys leading to end-stage kidney disease. This is a very old study that looked at blood pressure, looking at blood pressure and stroke mortality as well as ischemic heart disease mortality. And you can see that regardless of the age, there's just a linear relationship between hypertension and the risks of stroke and ischemic heart disease. And then the other really important thing is this was looking at hypertension globally. So for women and men, of the many individuals with hypertension, only about 23% of those are controlled and 18% of men are controlled. And so we know what we're doing actually isn't working. And I wanted to bring this up as well. So first poll is just what is the threshold for defining hypertension in adults? Is it A, more than 120 over 80, B, more than 130 over 80, C, more than 140 over 90, or D, more than 150 over 90? So the American Heart, the answer is 130 over 90. And so as of 2017, the American Heart Association released these guidelines for defining hypertension, with stage 1 hypertension being more than 130 over 90. So this is part of the ACA guidelines for when to treat hypertension. You'll notice that for individuals with stage 1 hypertension and an ASCVD risk of more than 10, then they should begin a pharmacological therapy as well as non-pharmacological therapy to lower their blood pressure. And for individuals who are kind of this pre-hypertension or non-pharmacological therapy is recommended, and then reassessing in 3 to 6 months. For folks with stage 2 hypertension more than 140 over 90, it's recommended to begin blood pressure medication immediately, regardless of the ASCVD risk. The reason why I really like this flow chart is that it very clearly outlines, number one, the there is a role for non-pharmacologic therapy, but that, when we really want to consider beginning blood pressure medications. And I will say that a lot of times folks will ask about the diastolic pressure. So whatever is higher, if it's kind of going back. So if your blood pressure is higher than, if your systolic is in, the 130 to 139 range, but the diastolic is 90, then more than 90, then that would be a stage 2 hypertension. And then this is just a reminder of the ASCVD risk estimator. So now that we've gone over what is recommended for all individuals by the AHA, I'm going to throw you a little bit of a side curveball here. So here's a case of a 45-year-old man with long-standing type 2 diabetes, hypertension, and CKD4 with nephrotic range proteinuria, a prior thalamic CVI. Medications are irbesartan 150, which is limited by hyperkalemia, and empagliflozin 25 milligrams, liraglutide, and aspirin. Here are the lists of blood pressures that he has. And so you can see, for the most part, it's in the 130s to 80 range. And then he has a one that's higher and then one that's lower than that. And he does not check blood pressures at home. So what would you recommend as a next step? No change. Have him check blood pressure at home, and if consistent with clinic values, add a second blood pressure medicine, refer for ambulatory blood pressure monitoring, or add a second blood pressure medicine. So I would say that he's only on irbesartan, and I would say, based on the next guidelines that I'm going to go over, the answer is probably D. So here's the history of blood pressure recommendations for individuals with chronic kidney disease. Back in, years ago in 2003, that JNC7 had a blood pressure of less than 130/80 for patients with CKD. And then the KDIGO guidelines in 2012 recommended less than 140/90 for patients with CKD, and then less than 130/80 for patients with albuminuria. And these were based on large landmark trials in around 2010. And then in 2017, based on the SPRINT study, the AHA recommended for individuals with CKD blood pressure less than 130/80. In 2021, KDIGO further updated the guidelines to systolic blood pressure, no diastolic threshold, less than 120 when tolerated, using standardized office blood pressure measurements. So in some ways you could say, B is correct because you want to get some home blood pressures as well. That's not wrong. But I think based on the KDIGO guidelines, the systolic blood pressure less than 120 is what would be recommended for this patient. And he's only on one blood pressure medicine at half dose. So I think it would be reasonable to start another blood pressure medicine. So I just want to go over these guidelines because they are practice changing for me. And it's the kidney disease, KDIGO stands for Kidney Disease Improving Global Outcomes. And these are the 2021 blood pressure guidelines that they recommend standardized office blood pressure measurements, and then also a systolic blood pressure less than 120 when tolerated. And the reason why they're recommended for standardized office blood pressure measurements and is because the SPRINT studies used those standardized methods. And so that's what really was driving this recommendation. So I'm going to quickly go over, the implications of this. When lowering the guideline from 130 to less than 120, it basically meant that, 24.5 million adults with CKD are above the goal of the target. And that's about 13.9% compared to the 2017 guidelines. And essentially, when you lower the target from less than 130 to 120, you can see that basically now there are 33.7 million additional adults with CKD that have blood pressure that we thought was in range, but actually isn't. So that's why I think this is really practice changing. Now, in order to really understand this, I think reviewing the SPRINT study and so it was a multi-center study with 9,000 patients over the age of who had CKD with a GFR of 20 to 60. These individuals did not have diabetes. They had it included individuals with very high risk cardiovascular disease. And they also include, and so they randomize individuals to intensive systolic blood pressure of less than 120 or the standard target of 135 to 139. And the primary outcome was MI, stroke, etc. And so during this trial, they followed the individuals for 3.26 years and found that a large separation between intensive in this, in this group with very high risk for the primary endpoint. And so, that's really what, and so I just want to call out, individuals with CKD and without diabetes. So with that, there were some recent changes to the ADA guidelines for blood pressure. So in 2017, the same year that the AHA guidelines were released, the ADA said that their recommendation was less than 140 over 90. And then recently in 2024, the now recommendation is the same, less than 130 over 80. And that's based on the SPRINT study. And so I'm going to go over this study, but this is a study that was kind of similar to the SPRINT study in terms of standard and intensified treatment. And they saw that there wasn't a difference in targeting the more intensive blood pressure target. And so I just think it's important to go over the 2024 guidelines and the rationale behind this change. They revisited the ACCORD and SPRINT studies. Their definition that they used for the ACCORD study was less than 120 or less than 140. So to answer your question, yeah. So when they reviewed the data and looked at it more intensely, I think the thought is that the ACCORD study was underpowered. The SPRINT study had over double the participants, potentially underpowered for that primary endpoint. And I think it shows, that the SPRINT study had a more kind of higher risk CVD population. And then the secondary but ACCORD did see a secondary outcome of a stroke that was significantly reduced. And really what ADA said in their guidelines was that there was no large randomized study that looked at individuals with diabetes that showed a reduction in their primary endpoint, but that there are enough studies of individuals without diabetes that they felt that it was, appropriate to lower their guidelines, lower the target and recommendation. So with all of these guidelines, I just wanted to go over my approach. I target 130 over 80 for all patients in terms of my goal blood pressure. And that's really because we see a reduction and we want the benefit of that reduction. And you can see in the SPRINT study, individuals were followed for 3.2 years. If you can lower someone's blood pressure in 3 years, within even a 1 year time, that's when the separation was started to see. So I really hard to get the patient's blood pressure and try to avoid treatment inertia. And so in patients with a systolic blood pressure of less than 130, but greater than 180, I don't further intensify the antihypertensive agent. I will, and I explain, I work with them. For individuals with CKD and who do have some home blood pressure readings, I do target a lower blood pressure target of 120. So I want to talk now about talking about the kidney protective medicines. And my understanding is you all had big entire talks on SGLT2 inhibitors and GLP-1 receptor agonists. So I won't go into a lot of the data supporting that, but I definitely want to talk about ACEs and ARBs, SGLT2 inhibitors, GLP-1s, and then MRAs. So this is a very old, this was the renal study that showed protection for individuals on an ACE or an ARB for at long term. This was individuals with type 2 diabetes and albuminuria. These are the KDIGO 2022 guidelines that ARB should be initiated in all patients with diabetes, hypertension, and albuminuria and titrated to the maximum tolerated dose. That's the recommendation by KDIGO. I just want to put a plug in because we see this so often with primary care getting nervous about individuals being on an ACE or an ARB as kidney function declines. Please don't stop the ACE or ARB. This was a study that was a retrospective propensity matched cohort in Pennsylvania. They looked at individuals that stopped the RAS inhibition within 6 months of progression to CKD4 and looked at, the survival probability and showed a protective effect of the ACE and ARB over time. So please continue it. This is going to be the summary slide for SGLT2 inhibitors and the impacts on the kidneys. So we know that there's just essentially a lot of different ways that the SGLT2 inhibitor protects the kidneys. There are 12 ways. I won't go into all of them, but this is a really nice summary slide that I like a lot. So this is a summary of the SGLT2 trials that have been done. And there are just, more studies showing that with a protective impact of when they're looking at worsening kidney function. So again, the guidelines are that it should be initiated in patients with type 2 diabetes, CKD, and GFR greater than or equal to 20. There's also recommendation of that it can be for diabetic and non-diabetic individuals with kidney disease. We continue the SGLT2 inhibitor after the GFR falls below 20 until they initiate dialysis. So please continue the SGLT2 inhibitor too. And right now, there aren't any studies supporting continuation of SGLT2 inhibitor after dialysis, but those studies are up and coming. Or they're in the process of doing a handful of studies. GLP-1 similarly impacts blood flow to the kidneys, and the thought is that in addition to diuresis, maybe increases the renal blood flow as well. I'm not going to go over that. I want to talk also, there are some studies the other important studies looking at MRAs that are classically avoided in CKD due to the risks of hyperkalemia, but they've been shown to be protective as well. So I want this to be in your mind. This is kind of like diabetic kidney disease, and you can even say like proteinuric kidney disease, kind of these 4 pillars of treatment. And these are the kidney protective medications: RAS inhibitors, SGLT2 inhibitors, finerenone, and GLP-1 agonists. So those are kind of these 4 pillars. Think of it like heart failure, where you have your beta blocker, your diuretic, and we're adding these on. And I typically go in this order too, but also, we'll often start GLP-1s now a little bit earlier as well. Okay, I'm so sorry, Karen, to rush this. Do you want me to pause here, Nicole, or do you want me to keep going? Okay. So this is the 2020 update for the KDIGO guidelines for nutrition. And so basically individuals with CKD 3-5 who we think the recommendation is to limit the protein in the diet, basically 0.6 grams per kilogram of body weight per day. And then there's also that individuals with CKD and diabetes kind of recommendation of going up to 0.8 grams per kilogram. And then, of course, limiting salt. So a lot of patients will ask, what do I do about my diet? And I just really stress more the salt. And unless, I tell patients please don't eat more than, a certain amount of protein. And the reason why is just because a lower protein diet will basically an excess of amino acids increases the intraglomerular pressure and causes hyperfiltration of the kidneys. So the idea is that lower protein intake leads to constriction of the afferent arterial, and then lowering the glomerular hyperfiltration. So it's kind of like adding on an extra ACE inhibitor without some of the side effects. All right. So there are concerns about a low protein diet. Number one is the adherence is quite low, and not everyone has like access to the registered dietitians. And then in terms of the effectiveness, what the KDIGO guidelines say is the certainty of the evidence is low or very low. It's possible that, though not yet equivocally proved, that nutritional interventions slow disease progression. So really, we don't have any cited studies in the guidelines themselves that recommend the low protein diet. So I don't even have studies to really go over that for you. My approach, I just remember 0.8, and I recommend essentially normal protein diets for patients. You can go up to 1.3 grams per kilogram per day if people are like, I just feel better with that, and then I will, calculate that out for them. I don't have different recommendations for people with or without diabetes, but I really recommend the low salt diets, both for people with proteinuria and hypertension. And then I don't recommend dietary phosphate restriction. I also don't recommend dietary potassium restriction because we know that high potassium diets are heart healthy. So until that's an issue for patients, I really actually tell them that I want them to eat plenty of potassium. So just to summarize, this has been really fun for me. I just want to remind you all that the goal blood pressure of less than 130/80, and then a systolic blood pressure of less than 120 if you're able. These are for individuals with kidney disease. And then we've got our 4 pillars, and just that protein restriction with CKD, there just aren't a lot of data supporting it, but that it can be, we went over the theoretical mechanism of that. So
Thank you so much, Laura. I'm going to start it off with a question. So I find with my patients, one of the biggest barriers is just barriers to taking multiple medications. So talk to us about how you choose that second and third blood pressure medication, and what are your tricks to keeping people on those medications?
ooh, I love this. This is a great question. And I feel like, don't you think that a specific hypertension talk is in order? I'd be happy to come back and talk about that. But the AHA recommendation is to use combo pills as you're able to do that. I've found that people still feel like they're still taking 2 pills, even though it's one, and they're like, I know that it's 2 though, but some patients, I think it really builds trust that when you can, tell them like that I'm going to give you this combo pill because I want you to take less pills. And so that helps a lot.
And then I'm actually going to ask this question to Karen before we move on to our case discussion. Is there any simple way, like the size of the palm of your hand, to estimate that 0.8 unit per kilogram protein so that it's easy for people, or you can teach it to people who potentially have a lower health literacy? How do you talk about low protein diet for those that have less health literacy?
Well, one of the things again is it comes down to it's rather complicated. I think when Laura had the thing about low adherence to the low protein diet, very true, because it is a bit more complicated. One of the things that makes things rather easy is getting it out of the gram number and into ounces. Because when we're looking at food labels, as an example, that number is listed in grams. But if you're talking about ounces of chicken or ounces of fish, we're talking about ounces of food, and that's a completely different number. For women, as a general rule, it's really easy because the length of our thumb is about the size of a string cheese, which is about an ounce, including the diameter. Men, it's a little more challenging. Their hands tend to be bigger. Usually it's an index finger, unfortunately, often a middle finger, but that just gives them that measure of a single ounce. And if, again, we translate that gram number into an ounces, and I give the patients at the Kidney Stone Center both numbers. I give them grams and ounces. And, it's like, and then I also talk about, because again, just looking at that protein load, it's like if your budget is 9 ounces a day, let's not eat 9 ounces at dinner. Let's try and get some of them at breakfast or with snacks, and not load it up all one time a day.
Great points there. And I can see how that can be then more reproducible for the patient. So thanks for those tips. And so there was a question, Laura, in the chat. I'm wondering if they were wondering about talking about how you approach proteinuria when the ACR stage of CKD is discordant to the GFR stage. Can you speak briefly on that? Well, Jessica calls up our case notes for the cases.
Yeah, I kind of break that up into two things. One is, the etiology, and then the other is the treatment. So I think the first thing, if the first thing to know is if there is very high ACR that seems out of proportion, not just to the kidney disease, but also like the longstanding hypertension or longstanding diabetes, they might need further workup. I think, a good, like if someone has no normal kidney function and more than like a gram per gram of ACR, I think that would probably need further workup if they don't have longstanding diabetes and hypertension that's handled. So that's like kind of the first approach is, making sure that they don't have some other podocytopathy or something like that. And then the other one is the treatment. And so, it really is maximizing each of those medications and checking frequently to see the improvement. And it's been for me, it's just at seeing these medicines come forward. I have patients with nephrotic range proteinuria who were able to get, the goal is, getting point or less than 0.3 grams per gram to prevent future injury to the kidneys, because proteinuria in itself is injurious to the kidneys. And so just really trying to be very diligent about escalating the medications until we're less than 0.3 grams per gram.
Okay, so 34-year-old female who came in mostly focused on weight management. She had developed prediabetes and high cholesterol, was working on food tracking, calorie restriction, tried to get her the GLP-1 receptor agonist. It was denied, and we weren't able to get prior authorization approved for that. I know we had, during the presentation, like my main questions were, should we slow down, like decrease the dose of phentermine because she was losing weight pretty rapidly, or just leave it? And then how to get the GLP-1 receptor agonist approved. And there was some recommendations on both of those things. We ended up not being able to get the GLP-1 approved. We did continue with the same dose of the phentermine. And I saw her once after that, and then she hasn't followed up since. So this is like the latest info that I had.
Big question for my patient was that her A1Cs were always in the 8s and 9s, but her GMI and her CGM was consistently in the 6s. And she had a lot of issues with hypoglycemia. So, and insurance covering her GLP-1s. The update is that insurance is all figured out. She is on Ozempic 0.5, having no side effects from it. And her CGMs look beautiful. There is about a 4% low on them, but none in the very low. And I'm becoming more comfortable with having a little percentage in the lows. And all of her lows are asymptomatic, so we're happy where she is and not messing with it.
Can I ask one follow-up question? I was curious about if she's had any weight loss yet that you know of?
Not that I know of. And then we did go through some testing to see if maybe there is some anemia or some changes to her RBC turnovers that might reflect or be a reason for the difference that we see. I didn't check her thiamine, but the other labs were all fairly normal. So I still don't know why there's such a big difference between the two.
Yes, and we'll talk a little bit about that. My other question is that one thing I noticed from her first report was that she had a significant amount of protein in her urine. Was that a new finding, and has that been repeated, or is it something that she's had long-standing proteinuria?
That is an ongoing proteinuria. Mm-hmm.
Okay. So she has had that, so serial proteinuria. Great. Thank you for that feedback. And we're going to start with the case of our patient who, as a follow-up, this person had many comorbidities. She was 49. She had diabetes, hypertension, hyperlipidemia, GERD with a BMI over 27. She was on a significant dose of insulin, 25 to 20 of Lantus, and then 5 of Novolog with meals, but she was having hypoglycemia via the CGM, although her A1Cs were high. And so at the initial visit, and she initially was reported to have intolerance to the GLP-1 receptor agonist. And I was going to stop there and just ask, did she start using her reflux medication more consistently? Was there anything that we changed, either like maybe avoiding caffeine, some dietary like spicy foods, or doing her reflux medication more regularly that you think helped support her then restart the GLP-1 without incident? Or do we not know?
No changes in the reflux. That's just gotten better.
And so who knows, maybe it was very
Was it the same GLP-1 that was used? We've found in kidney clinic that, switching people can have different side effects to the different, like Trulicity.
Yes, it was a retrial of the same GLP-1, but that's a great point. We find within the class that sometimes even if you're intolerant to liraglutide or some glutide, you may tolerate deglutide. So we will re-challenge with different within the classes. And then we've also find with our tirzepatide, our GIP, GLP, if it is formulary, less GI side effects, or at least people who have GI side effects from just the GLP-1 receptor agonists will potentially be able to tolerate the GIP GLP. So that's a great point, Laura. But the reason I was asking is was within the same class. But those would be some of my thought processes of it as well. Perhaps she did a dietary changes and was focusing on not overeating, smaller portion sizes. All those things can help with the GI side effect profile. Any other thoughts, Karen, on that?
Oh, I do want to add that we did not go back up to 1 milligram. We stayed at the 0.5 this time.
Yeah, and that was one of my points, is that some people are just slower in terms of their ability to titrate, so that they have to stay at the 0.25 longer before going to the 0.5. And then if they don't tolerate it, take it back down, wait longer before trying to accelerate it again, and even maybe doing some of the alternate, especially with Ozempic, that we have that luxury to do a little bit of alternate titration schedule. But I find that frequently with people, again, even just a little bit of diet advice in regards to doing a small, more frequent meal pattern, not getting over hungry, not eating beyond the fullness signal, eating more slowly, trying to avoid distracted eating, things like that, where we're not real good with keeping an eye on our portion size and listening to our body when we're full is a big piece that can help folks tolerate the GLP-1s better.
Great points, Karen. And, so it's great that we were able to basically get her off of insulin. Right now, she's on dual therapy with, as you said, 0.25 of semaglutide and 25 milligrams of empagliflozin. She does have consistent insurance, so we will always have to take that in account, what she can afford in the future if she does not have insurance. But what we're seeing here is that her GMI remains in the sixes, but her A1C is in the 8 still. And so, and when they look back at her CGM reports from October through December, she still was in the sixes, and yet the A1C remained discordant. And the other thing I want to highlight is I think we don't want to say we're comfortable with low blood sugars, right? We want to say that we aim for 0% low, but there is an issue of, is it a true low or is it a compression finding, especially in the asymptomatic? So I always tell people, if you have symptoms, believe your low blood sugar. But if you have zero symptoms, this is when you would want to try to encourage that person to check with a finger stick just to make sure that it truly was reading less than 70, because often it will be, 90 or higher, and that's why they are not symptomatic. And what we've done is we've replaced this patient with medications that have a low risk for low blood sugar. And so again, every diabetes medication has a risk for hypoglycemia, but what we've done is we've been able to choose medications that have a low risk for it. So the first question would be, do we believe the value? And then the second question is there anything we need to do about it? And I would say that if we have a few confirmation finger sticks that show that they are not accurate, then we can move forward and say that it's a compression row rather than low true hypoglycemia. And so you can see here, I just want to highlight, we always want to look at the low blood sugar first, right? And you can see she does still have a lot of glycemic variability. So great, less than 36 is the goal for the coefficient of variation. Even though she's meeting her time in range goal, I still think about these things as goals we want to meet as well. So we just want to be aware of it, because what we don't want to do is increase low blood sugars, true low blood sugars, by increase time and range. First, we get rid of low blood sugars, and then we work on increasing the time and range and decreasing that very high. So. And the next question is you're right. You did screen. The most common cause that I see, especially in women, is for iron deficiency, causing falsely elevated. But her ferritin was nice and robust. It was not less than 10, so it's unlikely she has iron deficiency anemia. We could draw a B12 to sort of round things out, but especially, but she's not on metformin, which increases our risk for low B12, and we unless she is eating a very restricted diet, it's unlikely that she's B12 deficient. The other thing is because of those low sugars over the night, it makes me also want to make sure that we review her alcohol intake, because remember, alcohol can suppress gluconeogenesis in the liver, and so you can have a low blood sugar from that, and also that can also falsely elevate the A1C. So do we have any data? Does she drink any alcohol at all? Does she report any alcohol intake?
She's a non-drinker, unfortunately.
Perfect.
I guess it's not unfortunate. It's good, but
Yeah. And what I'll tell you is, unfortunately, I agree. Like, I look for the things that we can rule out for the discordant, but probably only less than 50% of the time do I find a reason for it. But what I do is I use both fingerstick and the GMI data and the CGM data and the A1C, and then I look at that cumulative data, and that's how I make the decision. In her case, I probably would start documenting that the A1C may be falsely elevated, and we're using our CGM and fingerstick data for assessment of blood sugar, so that if she has a transition of care or someone else sees her, they do not base it on this. And I have had to clear people for surgery where their A1Cs are like 8.5, but I really believe their sugars are running by their fingersticks and by their CGM, running closer to average of 120s, 6s to 7s, and so they're cleared for surgery. So we do have to take that into account, and that's how we individualize things for our patients. But I think the frustration thing is we always want to look for that answer and find it, but a lot of times as physicians, we're just ruling things out, right? And then we're making our best cumulative judges based on the data. So that was just,
Can I add something?
yeah, go ahead, Savitha.
Yeah, so I think there's data from our own clinic by one of our colleagues, which actually shows that there's actually more discrepancy than we think between the A1C and the GMI. So it can be anywhere from 0.5 to 1%. So as Dr. Erhardt said, the discrepancy doesn't necessarily mean there's something, you have to look at the patterns, is really the takeaway.
And that's a great point. Supposedly up to 50% of GMI data will be 0.5 or more different from the A1C. And remember, we really say that if we were doing like a point of care versus a serum one, 0.3% is within the acceptable range. So we do have this range, and this is where it's the art of medicine, and we're really that's why it's important to synthesize all the data. So the other thing I just wanted to point out in this potential case is that I think what we also see from the CGM is she is having, especially at breakfast time, like hyperglycemia. So I was going to ask, and it persists above 200, 250 quite frequently and for longer than 2 hours. So I was going to ask Karen, how do you talk to people, especially about those breakfast foods, and make suggestions for a lower carbohydrate or higher quality breakfast so they don't see those postprandial spikes, especially when they tend to be most insulin resistant?
Well, one of the things, of course, is to focus a little bit on protein, because obviously these are the types of foods that don't raise glucose, as a lot of folks do. They don't want to take the time to make eggs in the morning, that things like Greek yogurt and other good protein sources. The other thing that I find interesting, not happened across the board, but every once in a while, people are caffeine reactors where you get this little spike in glucose because of the morning cup of coffee. And oddly enough, finishing breakfast with the coffee instead of having the coffee first, the food second, seems to pull a touch off the peak. So I have had it work. And if you go on Google or Insta or whatever and ask, you'll see these reports over and over. It's very anecdotal. Oddly enough, I am a caffeine reactor, and whenever I wear a sensor, it works for me.
Great points. And Casey, do you have any insight on her breakfast? It's okay if you don't, but anything you might target in this discussion based on what what Karen just said?
I can't remember exactly. I think on my original review of her, I did mark kind of what she ate for breakfast and lunch and for dinner. And I think it was toast and eggs, but that might be wrong.
And so it may just be that you want to eat the eggs first and then have the toast and then just try to make sure she's doing a 3 gram fiber, like extra fiber a meal or a smaller piece of toast, right? Because you can have a piece of toast could have 200 calories in it and be all and 0 fiber, or it could have 100 to 110 calories and have 3+ grams of fiber. So just talking a little bit about quality of food there. And then this is what I was going to actually ask Dr. Subramanian first. And this person, right, by her GMI, and we sort of believe that she's running the A1C of 6s, is on dual therapy, both a GLP-1 receptor agonist and a sodium glucose cotransporter inhibitor. And I think this answer becomes a little easier because what Casey notes is that she's had a long history of protein in the urine. But let's just pretend for a second that it could be a contaminant, right? Because it could be menstrual blood. It could have happened after she exercised. And so, if we didn't believe that she had protein in the urine, would you do dual therapy, or would you try to just take one off and maybe escalate the semaglutide if needed? What do you think about mitigating her risk versus cost to our healthcare system?
So essentially, to summarize your question, if this individual did not have positive urinary microalbumin, would you use one or the other? I think modern diabetes management involves looking at the individual. If this person needs weight loss versus, the degree of glycemic lowering versus weight lowering, I think a discussion with the patient, well, are they preferring orals versus injections? What do they need, individualizing? And I think I'd start with one and then add the other depending on the response. In the absence of CKD or albuminuria or cardiovascular disease, would I start one over the other? I would start a GLP-1 if the weight loss requirement is more versus an SGLT2 inhibitor, but there are people who are hesitant to start with injectables, so then I would start with the GLT2 inhibitor. That's what I would do.
Great points. And I think you practiced it similar to how I was thinking about it. I think because originally she was on up to 20 to 25 units of Lantus and potentially 5 units of Novolog. That's a pretty significant dose of insulin. I probably would reach first for the GLP-1 receptor agonist because we want a higher efficacy medication. And then I would potentially add on the sodium glucose cotransporter inhibitor if she needed additional coverage at the maximum dose of the GLP-1 receptor agonist, if she did not have proteinuria and she does have a normal GFR, right? But then in her case, she has over 200 milligrams of protein in her urine. So it puts her at, a higher risk for cardiovascular disease and for developing, and progressing to end stage renal disease. And so, what I also wanted to highlight and what Laura highlighted in her discussion was that we have, our older tool for looking at coronary artery risk scoring, because we're thinking about the whole patient here, and it's not just diabetes, it's what is their overall cardiovascular risk. So I was going to have Savitha first comment on the older calculation tool, and then we're going to show the newer calculation tool. So go ahead, Savitha.
Yeah, so what we typically use for cardiovascular risk reduction, atherosclerotic cardiovascular disease risk reduction, is what we call the PCE, or pooled cohort equations, which were released in 2013 and also in the 2018 ACC/AHA cholesterol reduction guidelines. So that's what you plug in. If you're using Epic or whichever EMR, it kind of automatically blows in, and you can assess the cardiovascular risk over the next 10 years, or what their 10-year risk is and what kind of statin dosing they need. And you can see here on the screen all the different variables that get entered. It's usually age, sex, total cholesterol, HDL, what the systolic blood pressure is, whether they're on treatment for hypertension, their smoking status is usually what gets plugged in there. You can see here that there's no LDL, there's no weight, there's nothing related to kidney or specific to diabetes, only yes or no. Also, the age that we use is between 40 and 75. So this, I wouldn't call this an old equation, but this is still widely used, and I would still encourage it to be used. But what Dr. Erhard is referred to is that there's a newer set of equations called the PREVENT equations. The expansion is predicting risk of CVD events. And so the ones we now use, the pool cohort equations, that's all built into our medical records, electronic medical records, is from 5 big studies. It includes people of Caucasian heritage as well as Blacks, not well represented by other races. So because of there are so many drawbacks to that equation, and in the last 10 years, there's been several changes in the landscape of how cardiovascular disease manifests. So it's not just myocardial infarction and stroke. There's a significant increase in heart failure. So now these new set of equations uses this 25 data sets with over 3 million adults. And these are what's called the PREVENT equations. It's from the American Heart Association, and you can Google it, and you can just Google AHA PREVENT. And it's the first, I think it's the first link that will show up if you Google it. And that's what this is. And the standard stuff that you put into this equation includes, in addition to what you saw on the previous slide, there's a few additional things that you can enter. You can enter the BMI, and you can enter the EGFR. And the reasons why this has changed is because there's been increase in, prediabetes, diabetes, kidney disease. All of these are important these are cardiometabolic risk factors. And so all of this has been incorporated into this PREVENT equations. And so that's what you see here. So the main base PREVENT, there's a base PREVENT model. And then on top of that, there's additional things you can enter, which includes the things that are shown to you on the left there, the UACR, so that you can include the UACR, the hemoglobin A1C, as well as for social determinants of health, you can also include a zip code if you know that. And then you can calculate that individual's risk, and you can see that down there. So there she's showing you the animation. So when you put the fact that this individual has positive urine microalbumin, their risk significantly increases from when it showed as, I think, 3% risk. Now the risk is 7.5 to 19.9. That's what this says is that you have, kidney disease, it adds to the risk. This individual has diabetes. Their risk is already very high. Diabetes is a cardiovascular risk equivalent. So keep that in mind. So they do need statin therapy, but these equations just add extra layers to refining their cardiovascular risk. So what dose would you pick, etc.
And so in this person's case, if I was worried they were truly still having symptomatic hypoglycemia, I may pull off the sodium glucose cotransport just for like a month to see if it mitigates the symptoms and the low blood sugars on the GMI. But because it would be so important to use the SGLT2 inhibitor, what I would probably do is if I added back the SGLT2 inhibitor, I may go down on the GLP-1 receptor agonist to see if on a lower dose we can still reach our glycemic targets, but also not have any symptomatic hypoglycemia. So just in this case scenario, it may be fine just to keep them on the current therapy they are because they're not having symptoms and we don't believe the overnight lows. We think they're compressions, but these are all just things that we can think about. And sometimes it is better to do things slow and steady. I think in this person, it was very appropriate to start dual therapy because because she was on such a high cumulative dose of insulin that she would need dual therapy, and we weren't sure how high we were going to get on the GLP-1 receptor agonist, but we could have done this as step therapy as long as we didn't let her be lost to follow up. So, and the final thing that I wanted to point out on this case was that, again, we're looking at beyond glycemic control. The good news is that Casey found the right potential diabetes therapies, but we want to address all her risk factors. And she did have some LFT abnormalities at baseline. I don't know if you were able to get a PTT so we could calculate her FIB4. but that would be something that I would definitely do and just potentially send her for elastography. Now, we're hoping because if she does get weight loss, she is on a GLP-1 receptor agonist, that we may see improvement of her MASH if she is at high risk for it, but it would just be something to discuss with her. And it may also, you never know what's going to be the motivator for people for continuing medications and utilizing them, right? And so this is a person who has early evidence of kidney dysfunction and potentially metabolic liver disease. And so talking to her about these processes, not to scare her, but to support her and say we want to address all these things, may be a way to make sure she continues her medications. And so this was just sort of my summary. And for the sake of time, I'm just going to go on to the next case. So this case now was a young woman who had a BMI of 50 plus. She'd really been struggling with a BMI between 50 and 59 over the years. She, had been motivated. So she had this readiness for change, but she tracks her calories. She had tried calorie restriction. She wasn't able to get a GLP-1 receptor agonist. And, appropriately, Dove attempted to support her lifestyle with medication adjunct. And, initially when she came in, she was having a lot of weight loss and doing great. But the question was, is if it was too rapid of weight loss. And so what we had talked about originally was, just holding at that dose and less. And, a good goal of weight loss is, 1 to 4 pounds a week. But if you go over maybe that 4 pounds a week, you could consider reducing it. I'd be curious, Karen, do you ever tell anyone a high end of weight loss, especially a woman versus a man?
No, it's the concern I always have with a high rate of weight loss is the unsustainability of it. And again, the concern that when they hit a plateau, that the weight rebounds rapidly as well. And just kind of a slow and steady wins the race, which when someone is BMI of 50, it can be a year's journey, which can be very discouraging, unfortunately.
Yep. And I think that's the most important thing is what we want to do is keep supporting her because she is engaged with her health. And so that's why if we do get the plateau is when I would potentially add topiramate in order to help suppress the appetite a little bit more. And I would go up to as high of dose of phentermine as the 37 milligram tablet, half a tablet twice a day. Usually I do it at breakfast and lunch so you don't have any activation, but it still has that suppressant effect by the dinner time. And then, this is a person I would say you're doing all the right things. So you're a great candidate potentially for bariatric surgery. And we know the most weight loss comes from bariatric surgery. And I would really like you to keep an open mind and consider it and consider initiating the process because it is like a year-long process. And one of those components is seeing nutrition on a regular basis. Karen, how do you talk to your patients about bariatric surgery? Because there's such stigma associated with being sent for surgery, but I actually think it is still our best weight loss tool out there.
And there's kind of two perceptions. One is that because I had to do surgery, I'm a failure. But the other is that surgery is the magic bullet. And surgery is amazing, but it does not unburden people. The amount of work, which is again, this why the monthly nutrition is I prep people. This is what your expectation. Working on, keeping a food log, which this woman's already doing, working on some of these pieces that help create success post-op. And one of the main things is as they approach their surgery date, there is a recommendation to really reduce the carbs in the diet, which when someone has diabetes can be more challenging because that means a lot of med adjustment potentially. But the shrinking the liver so they can do the surgery laparoscopically, which really is the surgeon's goal, and it should be the patient's goal as well because it reduces the post-op complications because it's 3 little holes, not a big wound, and that means they can be up on their feet sooner, discharged from the hospital sooner, some things like that.
And again, what we want to do, even if she ends up going to for bariatric surgery, the more weight she can lose before the surgery, the better candidate she is. And so the good news is Zepbound or tirzepatide was just approved for sleep apnea therapy. And this person has severe sleep apnea. And so I definitely would resubmit not under the Mounjaro tirzepatide, but I would resubmit for a sleep apnea indication for the tirzepatide. And hopefully that would get approved by her insurance. I probably would wait another 3 months so that it's more in the mainstream, but I'm hoping this is going to open up medication and metabolic management for some of these drugs for a sleep indication. And, it should just remind us to screen people for sleep apnea, because now we have a potential medical therapy for it as well. What are your thoughts about this, Savitha? I know it's like a newer recommendation.
Tirzepatide for sleep apnea, I think it's an excellent indication, because the tirzepatide can give you weight loss to the extent of bariatric surgery, so much so the bariatric surgeons may be going out of business, and there are newer drugs that are coming out potentially which have very significant weight loss. So I think while bariatric surgery is an option, I think I would try to fight the insurance for tirzepatide and just go back to them and appeal it. And I know you have to be your advocate for your patient a little bit, and maybe have the patient advocate for themselves also if it's possible. But I think with this new indication, this individual definitely should try. We should try to get her tirzepatide.
Yeah, this is someone every 6 months I'd resubmit and ask for it, and hopefully I would wear them down. So
Yeah, pretty much.
Oh.
You got to wear them down.
And so finally, the only other thing I was questioning we want to scrub the medication list always for anything that doesn't help people lose weight, right? And so she is on SSRI, and this was just a big database look at as compared to Zoloft. I looked at the average amount of weight gain across the board, and you can see that in general, the medication fluoxetine that she was on did not significantly increase the risk for more weight gain. We know that bupropion or Wellbutrin is the one that tends to cause a little bit of weight loss. And then I was actually surprised that our citalopram or Lexapro actually was the one that potentially caused a little bit more weight gain. I was not familiar with that literature. So again, I always if I'm not sure about the potential for weight loss or weight gain, I just sort of run all their med lists, because what we want to do is support their whole body health and find any little thing that might help them in their weight loss journey. And then the final thing with our last 2 minutes that I want to just discuss is that, I know this person has tried a lot of nutritional options, but we do know when you do very calorie restricted diets, you do see weight loss. And I would say, since she's doing so many other good things in her activity and her nutrition overall, the hope would be that potentially very low calorie diet might be a jump start, and then she might maintain a large proportion of that weight loss. So Karen, can you talk a little bit about very low calorie diets and like safety issues and how you go about recommending them to people?
Well, one of the things is with the very low calorie diet, the note on the bottom requires close supervision, because again, we really want to make sure that it is fat loss, not lean loss, and that the potential for lean loss can occur. And even, the micronutrient deficiency. For many of them, the more structured program, this is covered. There's focusing on adequate protein, focusing on adequate micronutrients. But the one thing that always concerns me about a very low calorie diet is that we learn how to lose weight with a very low calorie diet, and we have our current eating habits, and we don't have anything in between that's part of weight management, weight maintenance. And so that is the one thing that, this again, rapid weight loss. So these people hang on to it, and it's like, well, now we need to transition to a more weight maintenance type plan. They just don't have the skill set. So without the learning that goes along with it, that's my concern with some of these very low calorie diets. More structured programs tend to support that learning and that management, avoiding using food for stress relief and emotional issues. But without that support, they're not really sustainable and potentially may not be safe.
Thank you for that update. So, a lot of good questions, and this is the art of medicine. Hopefully, with this case follow-ups, what you saw is that, even if one parameter is looking good, we want to keep asking and thinking about whole body health for our patients. And so, on that note, I will say this ends session 9 of the Cardiometabolic Echo.